So this case, which I'm going to present, has seen senior house officers becoming registrars and registrars becoming fellows and fellows becoming consultants. So what is the first question you like to ask when you see such an X-ray? I'm sure.
Oops.
Who did it?
Oops.
Truly asking, you ask, who did it and where was it done? You know, because you feel, I want to know who did this case. Anyway, so 72 years old gentleman, he has a previous acetabulum fracture, simple, straightforward case, hip replacement, right? Any critiques, please? So this is the immediate post-op X-ray. So bone grafted, lateralized the hip center, small head, cemented stem. Please feel free to critique it.
Any comments from the panel on this? Why such a small head, out of curiosity?
Yeah, it's a smaller head. I'm worried about the offset as well. And, you know, I don't have an offset. And the stem is quite far in, and I think it's undersized.
Yeah.
Stem is undersized, and that's why you don't have the offset. So with Exeter, as you go up the sizes, you also go up the offset.
Offsets. Yeah. So that's what happens as expected. And what would you do for the first time? Put back in. That's what was done. So we put back in and hoping nothing will happen. It should settle down. Unfortunately, again comes out. So goes in, comes out, goes in, comes out many times, and always reduced in the emergency department. Revision was planned. Right. So what was done? Increase the head size. So as you said, the head is smaller, so head size has been increased, Dr. Jurani, and neck length has also been increased. So anything here now, I mean, we could have improved further.
Any thoughts?
The important thing is the version of the stem. If was the version of the stem right, that's the important thing.
I wish you didn't answer that.
Yeah, because you may increase the head size as much as you want to, but if the version is not right, it will dislocate again.
Right. Let's find a solution. Comes out again.
Both acetabular and femoral version needs to be,
So-
by CT scan.
It's a skirted neck, so I personally don't like it. It would impinge. Reduced again. Comes out again. Let's do another revision. So this patient, because of multiple dislocations, and all the time it would come in the emergency department. Now I'm fed up, patient is 73. Anything wrong here? So constraint liner, fantastic. It's not going to come out now. Patient is 75, I guess. So I don't think that much of activity. The liner should live longer than the life.
It came out.
You're showing a dislocation of a constraint liner?
Yeah, I think that's coming next.
Yeah,
It's
that's
coming next.
I think
So
that was coming.
this comes out again. So in such a situation, you want all your friends and enemies, send it to them, take multiple opinions, send it to your neighbors. This had to be reduced in OT because it's a constraint liner. It's never going to go back in the emergency department. So it went in to come back again.
I think a
Now
good
what?
Yeah.
Now what do we do from here, please? I really want someone to guide the surgeon what to do from here.
So the anteversion of the cup and the stem both need to be assessed very carefully.
Do you think it is abnormal on this?
Cup is retroverted and so should be the stem, looks like.
Well, I feel the sharp edge is seen. Probably it's neutral, if at all, because you can see front and back of the cup in the same line.
Yeah, so it's neutral. So that's retroversion actually.
Renal.
I would like to revise both the cup and the stem.
With what?
Cup with the revision cup and the stem with the modular stem.
So, revision cup, right? So, how are you going to prevent dislocation then?
Can you do a CT scan?
The problem, unfortunately, I do not have the CT films. I don't even, so I'm really sorry for
The
that.
problem here is probably the component malpositioning.
So
And once
we-
you put them in the proper position, you don't need anything else.
What about the soft tissues after having so many dislocations? You would still rely on your revision cup
Judge
and revision
intraoperatively,
stem?
and you can put in a dual mobility if you wish to.
That time, dual mobility wasn't available. That's why constraint liners have been used.
There is an old pelvic fracture which is also tilting the pelvis posteriorly. So if you see there is a superior inferior pubic ramus fracture which is also malunited. So that's also
Right.
retroverting.
So we thought we should go to philosophy of Dr. Vijay Bose now. He's seeing, looking at me, and third revision was planned. Here we are. Let's put a biggest sized head as we can. okay, and large diameter metal on metal. I'm sure now it's not going to come.
You did the case. So my question would be, did you really assess everything properly? Because, as we said, there was a fracture, probably there's malrotation of the stem, probably there's a retroversion of the cup. What was here the combined anteversion? You measured it intraoperatively.
See, the first time it wasn't me. As I said, this case has seen senior house officers becoming fellows and consultants. So, but yes, somewhere down the line I was involved in this case from this part. This metal on metal was done, the stem anteversion was found to be okay, and large head, so we have got a good jump distance now. It should not dislocate. And actually, this did well. Unfortunately, patient developed LVAL, metal on metal allergic reaction, which caused dislocation. And this was one of the first cases in our center we picked up that metal on metal can get a dislocation. So here we are. Now this dislocates. So this patient had countless dislocations and 4 revision surgeries. Now, how do we take it from here? So we know it has dislocated. There is a metal on metal debris which would have eaten the soft tissues, which did actually, because all the abductors were necrotic. I don't have the video, I haven't put it. And this guy's fed up. He's really so scared to walk because he feels something is wrong with him. That so many surgeries with all good principles.
Yeah.
So I'll just share. So finally, as Dr. Jurani pointed out, the stem actually was neutral, and so everything was revised. So you need to think of multiple factors: patient factors, surgeon experience, implant factors, the type of implant, the orientation of the implant, and of course the, beg your pardon, soft tissue factors of the patients. So cup was revised, the constraint liner was used. And the most important part was the abductors were lax. So we had to get it down and do a trochanteric osteotomy so that we have a right tension. And there is a follow-up of 8 years now. Hasn't dislocated since yet. So thank you.
May I have a question? So another option could be an easier one, would be a cement and cement revision. So just pull out the stem, put it in another version, and re-cement it. That would be
Absolutely, but we
probably-
wanted to get the trochanter down actually. Trochanteric osteotomy. We wanted to tension the abductors. They were lax.
Yeah, but you can re-cement a stem which is looking out a little bit,
Yeah,
to lengthen it,
sure.
without all the osteotomy, without the metal.
I'm sure we can.
Well, amazing case. I think it highlights, we have one more case to go. I think it highlights, do the revision correctly the first time. You know, I think changing the bearings, we saw every different bearing combination and it wasn't working.
Yeah.
You know, don't try the same thing twice, expect a different outcome. And if a bearing exchange doesn't work, don't just keep doing more bearings, right?
I don't know, but
know?
I think this patient had 30 dislocations.
Yeah. Sit to stand, CT scan, planning, right? And so, yeah.